Let's consider a final scenario that truly ties together the need for this kind of vigilance we've been talking about today. Imagine a seemingly healthy 25-year-old man, a dedicated competitive athlete who is undergoing a routine pre-participation physical. His ECG shows very subtle, persistent ST segment depression in leads V2, V6. What's even stranger is that this depression worsens during a stress test. He has no history of chest pain or any other typical cardiac symptoms that would suggest, say, coronary artery disease. Without the kind of deep dive we've had today into unusual ECG patterns, this subtle finding might easily be dismissed as an anomaly, or perhaps misattributed. But because of our discussion and the insights we've shared, this pattern immediately flags a concern for something like Bundgaard syndrome.
This case perfectly illustrates the core importance of what we've been discussing. It's about recognizing these subtle yet incredibly specific electrical patterns that can be the only early warning sign of a potentially life-threatening inherited arrhythmia. Even in seemingly asymptomatic individuals, these ECG findings are precious clues. It underscores that being well-informed about these rare syndromes is not merely an academic exercise. It is profoundly, clinically critical for early detection and intervention, and it can quite literally save a life. It turns a seemingly insignificant detail into a vital piece of the puzzle. 2-second quiet. So what are the most crucial takeaways from our deep dive into these rare and often under-recognized ECG syndromes today? What should people really remember? Well, there are a few key points I hope our listeners will carry with them. First, the ECG is still a cornerstone, but nuance is absolutely key. The electrocardiogram remains fundamental, no doubt, but its full diagnostic power is truly unlocked only when clinicians and informed individuals like you are aware of and can recognize these subtle and often atypical patterns. Many of these rare syndromes present with unique electrical signatures that, once learned, can be incredibly indicative.
Right, it's not just about the big obvious things.
Second, look beyond the common. While common cardiac emergencies are very well understood, these rare syndromes, despite their lower prevalence, carry a disproportionately high risk of sudden cardiac death, especially in seemingly healthy young individuals or those without obvious symptoms. Awareness is the very first step in prevention. Third, embrace those multi-systemic connections. As we've seen with conditions like Jervell and Lange-Nielsen or Naxos or Danon disease, the heart's electrical health is often intricately intertwined with other organ systems. Features like congenital deafness, unique facial characteristics, specific skin conditions, or even muscle weakness can be vital clues. When you combine those with careful ECG findings, they can point directly to a specific, otherwise hidden diagnosis. It's about connecting seemingly disparate pieces.
Connecting the dots.
Fourth, genetic testing is transformative. For many of these inherited conditions, genetic testing plays an absolutely crucial role. It not only helps confirm a diagnosis, but is also vital for guiding risk stratification, understanding how severe the condition might be, and for effective family screening. This moves us from simply managing symptoms to providing personalized and truly preventative care.
That's huge for families.
Fifth, proactive management is life-saving. From the use of specific medications like beta blockers to life-saving devices like ICDs to necessary lifestyle modifications and sometimes specialized surgeries. Early and appropriate intervention based on an accurate diagnosis can profoundly alter the natural history of these challenging conditions and significantly improve patient outcomes. It's the difference between a tragic unknown and a manageable condition.
Okay.
And finally, the power of detailed history and comprehensive evaluation. A thorough personal and family medical history combined with meticulous ECG interpretation and targeted additional investigations is absolutely essential. It's how clinicians truly connect those dots, avoid misdiagnosis, and ensure that treatment isn't delayed, ultimately making a tangible difference in patients' lives. 2-second quiet.
Now, let's test your knowledge from today's deep dive with a few multiple-choice questions. No pressure, just a chance to reinforce what you've learned and see what stuck.
Exactly. Remember, these are based purely on the fascinating facts we've just unpacked and are designed to make you think about those unique aspects of each syndrome. Question 1. Which ECG syndrome is characterized by a triad of periodic paralysis, ventricular arrhythmias, and distinctive facial or skeletal dysmorphisms, and where the QTC interval may even be normal? A. Timothy syndrome. B. Andersen-Tawil syndrome. C. Short QT syndrome. Bundgaard syndrome.
The triad.
Question 2. In which syndrome is the hallmark ECG finding a markedly prolonged QTC, typically exceeding 500 meters, often alongside profound congenital bilateral sensorineural hearing loss? A. Romano syndrome. B. Long QT syndrome type 3C, Jervell and Lange-Nielsen syndrome. D. Noonan syndrome.
Prolonged QTC plus deafness.
Question 3. What is a common and distinctive non-cardiac feature of Naxos disease that often appears from birth and is suggested to indicate a poor cardiovascular prognosis? A. Prominent ear tags. B. Curly and woolly hair. C. Blue sclera. Hypoplastic mandible.
The hair thing.
Question 4. BRASH syndrome involves a dangerous cycle where acute kidney injury and hyperkalemia exacerbate bradycardia due to the synergistic effects of which class of common heart medications? A. Statins. B. Antibiotics. C. And AV nodal blockers. Anticoagulants.
Vicious cycle.
Question 5. Which syndrome is characterized by a shortened QTc interval that shows inadequate prolongation during bradycardia and excessive shortening during tachycardia, a phenomenon known as pseudonormalization? A. Long QT syndrome. B. Brugada syndrome.
Yeah.
Short QT syndrome. Early repolarization syndrome.
The QTc not adapting right.
Question 6. What unique and characteristic ECG finding can be observed in Andersen-Tawil syndrome even when the overall QTc duration is not dramatically prolonged? Deep S waves in V1, V3. Prominent U waves in leads V2, VC. Markedly short PR interval. D. ST segment elevation in lead AVR.
ATS. Besides the QTc.
Question 7. Which characteristic ECG finding is often observed in Noonan syndrome, potentially independent of underlying structural heart defects, making it a unique electrical marker? A. Right axis deviation. B. Abnormal RS ratio over the left precordium. C. Markedly short PR interval. D. Deep S waves in V1, V3.
Noonan's specific ECG trait.
Question 8. In long QT syndrome, what is the most common life-threatening arrhythmia, often described as twisting of the points on the ECG, and typically triggered by a long-short sequence? A. Atrial fibrillation. B. Ventricular fibrillation. C. Torsades de points. D. Supraventricular tachycardia.
The twisting one.
Question 9. For patients with short QT syndrome, what is considered the cornerstone of management due to the high risk of sudden cardiac death? A. Daily aspirin therapy. B. Long-term oral antiarrhythmic drugs only. C. Implantable cardioverter defibrillator, ICD therapy. A. Cardiac ablation as first-line treatment.
Managing SQTS risk.
Question 10. Which genetic condition, characterized by distinctive physical features and congenital heart defects, affects the critical RAS-MAPK signaling pathway, essential for cellular growth and organ development? A. Jervell and Lange-Nielsen syndrome. B. Andersen-Tawil syndrome. C. Noonan syndrome. D. Naxos disease.
The pathway one. Okay, let's reveal the answers. How did everyone do?
All right, here we go. 1B, Andersen-Tawil syndrome. That's the one with the classic triad of periodic paralysis, arrhythmias, and dysmorphic features. And remember, the QTc might be normal or only mildly prolonged. 2C, Jervell and Lange-Nielsen syndrome. This is the autosomal recessive condition combining profound congenital deafness with that markedly prolonged QTc, usually over 500 meters. 3B, curly and woolly hair. This distinctive hair texture from birth is a key feature of Naxos disease and is thought to correlate with cardiovascular risk. 4C, AV nodal blockers. BRASH syndrome is specifically about the dangerous interaction between AV nodal blockers, like beta blockers, and A-key hyperkalemia. 5C, short QT syndrome. That failure of the QTc to adapt properly to the heart rate changes, pseudonormalization, is a hallmark of SQTS. 6B, prominent U waves in leads V2, V4. These prominent U waves are a very characteristic ECG finding in ATS, often more helpful than the QTc duration itself. 7B, abnormal RS ratio over the left precordium, along with left axis deviation. This is a distinctive ECG feature often seen in Noonan syndrome, potentially independent of structural heart issues. 8C, torsades de points.
TDP is the classic, dangerous polymorphic ventricular tachycardia associated with long QT syndrome. 9C, implantable cardioverter defibrillator, ICD therapy. Given the very high risk of sudden death in SQTS, ICDs are the primary preventative strategy. 10C, Noonan syndrome. This condition stems from mutations affecting the crucial RAS-MAP-Kaplan-Meier signaling pathway, leading to its wide range of developmental effects. 2-second quiet.
That brings us to the end and another enlightening deep dive. Wow. We've journeyed through complex genetic channelopathies, explored conditions where the body systems intertwine in really unexpected ways, and even touched on acute compounding medical emergencies, all with the humble ECG as our guide, revealing these hidden stories.
Our sincere hope is that this deep dive has not only informed you, but also equips you with a heightened awareness. Understanding these rare syndromes is truly crucial because timely recognition and appropriate intervention can genuinely save lives, particularly in those individuals who might otherwise be dismissed as seemingly healthy until, well, tragic event occurs. It's really about empowering you with knowledge.
It truly underscores that the human body, especially the heart, is full of incredible complexities and hidden stories just waiting for a closer look. So, what's a provocative thought to leave our listener with today? Something for them to mull over long after this deep dive ends.
Consider this. If a simple electrical tracing of the heart can reveal such profound and life-altering secrets, pointing to conditions that can mean the difference between life and death, what other subtle signals in our lives, both personal and professional, might we be overlooking that hold equally vital insights, simply waiting for our deeper attention?
A powerful thought indeed. Thank you for joining us on this deep dive. We look forward to exploring more fascinating topics with you next time.